That's fine. So I'm gonna go and do the C-section here a little bit more. There's a lot to cover, so hopefully I can get at least to deliver the baby and maybe even close the uterus. But last time we did kind of doing the cut, and now we're gonna start and do the actual C-section. So how can I get rid of this again?
Sure, I'll try.
I can remove the top of doesn't matter what. Not a big deal.
It's supposed to be a clean.
Oh. I can show you.
Oh. I'm not sure.
Yeah.
See them being.
We're going to get rid of this.
Supposed
the
to
top.
have a pin here, but I don't know.
How we go?
But can you just get it again? Don't find me.
There you go. Beautiful. Thank you, thank you. So, the skin incision, transverse. Remember that, C-section when it first came around was done vertical, but now it's done almost all the time transverse. There are all kinds of different names, and we'll go over some of this, Van Stil versus Joel Cohen versus Stark technique, from this guy, Michael Stark from Israel. Most of the time, the studies, and there are many randomized studies, don't only do the skin incision, but the other levels together. So it's hard to pinpoint, but we do know that the transverse incision on the skin heals better. The only thing, if you're going quickly, and if you need the time, like let's say if you have nurturing field testing, a bradycardia, etc., that if you do a vertical, you save 1 minute in a primary C-section and 2 minutes in a repeat C-section. That's from the NICHD 0 section study. So if you really think that a minute in your primary C-section is going to make a difference on your, pH of the baby, etc., then that's when you should think about a vertical. But nowadays, pretty much otherwise you shouldn't. And there's not that much data on how big that skin incision, called bikini cut should be, but just make it big enough that the baby comes out, and I just see it so many times.
Baby sized.
You make it, 8 centimeters, the baby's term is going to have a height of 10 at least.
Yeah.
The baby's not going to fit. Just make it big enough.
I don't even know it's here.
As you know, really not much.
All the time. I don't.
Not much on randomized studies, but Rebecca did this randomized study here at Jefferson. She was kind of comparing Joel Cohen versus Van Stil in patients with a BMI of 35 or more. Oops, what did I do? Put that slide in. Sorry. But she didn't find a difference. So Van Stil most of the time in these patients is going to be below the pannus. While Joel Cohen is going to be above the pannus, closer to the umbilicus. And overall, she didn't find a difference, but patient and physician satisfaction and some of the secondary outcomes were actually better for Van Stil. So I think that if you're putting kind of the incision and the crease in very obese people with a pannus, you can be reassured that this seems to be safe. But obviously, it's with just one randomized study, 72 patients randomized, not that big. So there's some data that you should open the subcutaneous tissue bluntly. There's some data that if you use the BOVI versus the scalpel, you have a little bit better outcomes in terms of blood loss and pain, but we don't know about long-term effects like adhesions and things like that. So I think there's some evidence for just once the skin is open to go bluntly or below. You can also extend the fascial incision bluntly. And you can see here this randomized study that looked at many different things. It's the Quran is famous randomized trial published in the Lancet. Show that again, if you use your fingers to extend the fascial incision, once you make it, you'll have slightly bigger, slightly better outcomes. And also, obviously, you do it quicker.
Did they found significant differences in the EVI?
Yeah. I'm only going to list, the slides are always the same. You know, list randomized studies or meta-analysis, and what I list it's significant, unless I state so. So yeah. And it will make sense, you know, if you do it bluntly, maybe you're cutting less vessels.
I love blunt.
With a scalpel. There's actually this randomized study small that says that you could probably do away with dissecting the fascia of the rectus. You know, I still see a lot of people doing this. Again, it's limited benefit, limited data, but there's randomized studies that say that if you do it, you lose a little bit more blood, makes sense, and you have a little bit more pain, makes a little bit of sense, no benefit. Again, if you need the space and if you're used to it, and you have a big baby, or maybe the presentation is not what you like. I'm not saying not to do it, but if you skip it, I think you have some that'd be okay. And then, I like to enter bluntly. Some people use scissors or scalpel. I think, especially now repeat, it makes sense to enter bluntly. Not much in terms of data for this, but I go, as I can in the abdomen and enter bluntly. Not much data in terms of level 1 evidence for bladder retractor, but we do use that. Makes sense. I found this meta-analysis of 6 randomized studies using the Alexis retractor. This is especially in obese people to get more exposure. They didn't find benefit or harm in terms of wound infection or blood loss. For example, Federica loves this. She scrubs with midwives, so she doesn't have too much help. She's doing the C-section all by herself, and she says this makes a big difference.
Oh, wow.
But we've used it in the past. We used to have it.
We used to use it. I found the current tape thing that we have to be so effective that I don't think.
Taping the abdomen.
Yeah, there's like a special
It's so
system they
good.
have now that actually works very, very well. The Traxi, I was like, what's it called? I
Full name.
love it. Yeah, Traxi. Oh my gosh, compared to, yeah.
I just used to use 2 IO bands.
I know, but that does not work as well. I've had like really great experience with the Traxi. Someone BMI was 45 to 50 and it was like, you didn't even notice. That was not part of like the surgical issues, it was. So.
Yeah.
Do we have it here
I
at
don't have them
Jefferson?
anymore on L&D.
Say it again?
I don't even know if we have these on L&D.
We do.
I haven't seen them.
Yeah,
We have it.
I think now that we have the Traxi, we
They
don't.
have them, you just need to ask for them.
There was that.
Or maybe.
Was it
probably.
last time Manowar, they brought up all kind of weird sizes, taxi during ultrasound?
Yes,
Or
for
what?
amnio, I
Yes, yeah.
think.
Or something like a sonographer fatigue or something.
Oh, you're right. No, that was for
Yeah.
it was for scanning
Yeah,
obese patients
they
to see if
think
it helped
it's good.
scanning. Yeah. I didn't know. I know.
So bladder flap, haven't done it in a while, and because of this data, so it takes a little bit of time to do. There's a non-significant, more blood loss if you do a bladder flap, makes sense. The issue is, again, there are randomized studies and meta-analysis, but it's kind of like VTE. You would have to study thousands and thousands because the incidence of bladder injuries is so low. So you do it maybe to save the bladder, but you would have to study, like you see, 40,000 people to get a good sample size. You end up having more adhesions if you do a bladder flap. So I think given what we have, and again, it's good safe for I think a lot of us who skipped it, it's quite okay not to do the bladder flap. The uterine incision should be transverse. Again, when C-section was devised, was first vertical, but transverse makes a lot more sense. It's less blood loss, easier to perform and to repair, and obviously there is the issue of toe locking in the future, which you can do transverse. There are randomized studies on how you expand the uterine incision, and the data is for expanding it bluntly. So once you're in, beginning with the knife. I usually like to go in with a finger so that I don't injure the baby. There are many lawsuits, unfortunately, that you get the scalpel on the baby. It's kind of hard to defend. And sometimes it's minimal. And also expanding it bluntly with your fingers, less blood loss, less transfusion, less time, less chance of having the baby. And then that expansion, not only with the fingers, but doing up and down, cephalocaudal, a couple of randomized studies there. Minimal analysis showing also less urine extensions, which
I hear Sonia all the time, but she's always telling the residents to feel, like cut and feel, cut and feel. And I love it. And it's so true. People are just like me. Yeah.
Because they can cut it.
Exactly.
I heard of a case recently that the bow was cut, the C-section, the fetal bow. So not only
Oh my God.
skin,
Did they go that far?
but they had to,
Wow.
the baby had the bow resection. I mean, I don't know what happened, but
They felt like the fetal
It was
abdomen was the uterus.
It was certainly an arrest
They just
section
went
where
too
they had
far.
like.
and I know it was an emergency section. I heard not hospital
How
stuff.
is the abdomen
But
down?
how do you?
But
That's. I mean, that's
Anyway.
not good. Yeah.
I do want to go back to that slide, Vincenzo.
This one?
Yeah, because sometimes really that low uterine segment is very thick. And sometimes you're going to learn how to handle a bandage scissors because, on occasions I'll tell, it's really tight. And I'd rather you use the bandage scissors and make it enough to get a baby out so that the baby doesn't get stuck. The problem now is that many of the learners do not know how to hold a bandage scissors to get a uterine segment, sadly. Some of the residents.
fingers inside and guide.
I know, for me and you, it's very easy. Can you imagine me having to explain to them in the moment? In the moment, you have to explain to them. So I just hope that, the fellows and us also try to at least do a mock. Hey, if you had to use the scissors, I'll put my fingers, dissect, and boom. It's really easy. Okay? That's it. That's
Yeah.
my feedback for this. Thank you.
It does take some force, especially if you have a uterus that is not labored.
Or you're doing classical.
And right to
So what happened is-
expand the incision.
in this situation, the operator is desperate and you just want to have the baby out no matter what, and then you cross far. You don't know, you're in adrenaline. Then you have
Yeah, another thing, like a labor uterus, a lot of times you could just use like one incision and then you could easily enter bluntly. So like when they're laboring, especially like second stage, you always have to be careful of that.
And I didn't put it in the slides, but the level you do the incision is really important. Rodney, obviously you're bringing it up. If somebody's been in the second stage, a couple hours or more, you tend to cut in the cervix actually because the Lawrence uterus segment is so long and the cervix has come up. So you should make the incision, 2, 3, 4 centimeters higher than you think. And you should. Sometimes you can look at a bladder refraction and make sure you're above it, obviously. But just be careful because, as you know, even preterm birth is increased in the next pregnancy probably because we do cut the uterus at the cervix, not at the lower uterine segment when we do a second stage C-section. So.
I don't know if you had it here, but in my residency, we did a blunt dissection, 2 operators pull in each corner, and here you do 1 operator pull in each hand. And again,
So
what are
cephalocaudal.
we doing?
Yeah, so there are these 2 trials, again, almost 1,000 people, like that's meta-analysis. And they were pretty convincing that if you do it up and down, and again, you could take, I guess, a person pulling down, a person pulling up, you end up having less blood loss, less extension, and less need for additional stitches when you repair. So I think, again, it's not 10,000 people randomized and 10 trials, but seems to be the better way. And it makes sense, if you pull the transverse, eventually you may get to the urine one more, then you go.
It just feels sometimes the incision is not big enough and then the baby is not coming and
Yeah.
they struggle with extraction because the incision is not large enough for the head.
I think that's about making it like the right curve, and then also when you're cutting, not going like to smaller and smaller, like you.
Yeah, they like funneling.
Yeah, exactly, and then it's like 1 centimeter that they're.
You're gonna go through this whole thing eventually, so.
But these are, it's amazing how, we know more than we know years ago, but how many times you see people struggling to get the baby out? Or you see extensions, you see, urine arteries bleeding. It's really important we continue to look at this, and
Yeah.
small details make a huge difference.
So the answer to your question is a lot.
Is it what?
It's a lot.
It's a lot.
So baby comes out, and then, next thing, as everybody's taking care of the baby, et cetera, is placenta removal. And this we've known for a long time. We used to go after and take the baby out, the placenta out manually, but we know now that if you just do cord tractions and try to take it out spontaneously, there's less blood loss, less endometritis, and less hospital stay compared to manual removal. So that's been pretty, obviously, if she's bleeding a lot, or you can't take it out that way, or whatever, you should learn how to manually remove the placenta, but routinely you should try to do it spontaneously. There is some data. This is I have actually more updated slide set, but there's limited data on, we all curettes, we
Is this what we do with our hand, or you are?
no, we don't wear a
With a
hand.
sponge.
We use a
When
sponge,
you cut
right?
clean sponge and
clean
like the membranes.
Yeah, to clean them, to make sure there's no membranes or whatever, and there are like a couple randomized studies on there showing no difference. I think we're going to continue to do it, but I've seen people curette with a
bunch of
large curette around the world. I've seen people putting iodide in. Some people irrigate. I think there's no evidence for those things, but just you to be aware. Obviously, the uterus should be clean, should be without, placenta remains.
placenta, but some are obsessed to remove the deciduum.
Right.
And you can leave a scarring tissue.
Ackermans.
Very good for
Right.
Ackermans or Akrita next time.
Yeah, exactly. Yeah. More drop for a band. Anyway, there's no need. Some people, especially if you have a no lip, whose cervix is closed, let's say breech C-section, would go and open the cervix with punch forceps, and there are 3 randomized studies saying that there's no need for that. You may cause injury, but the 3 randomized studies didn't show any benefit or on open the cervix at the end of the C-section. And there is evidence that blunt needles are associated as suspected with less glove perforations, but apparently as we don't like it that those blunt needles that much. So I think we're all still using short needles.
Yeah,
as far as I know.
I'm sure used a blunt needle before.
Yeah.
Can I comment on 2 things here for this
Yeah,
slide?
please.
No, this I love your teaching, Dr. Berghella. This is really great for all of us. Now, the manual placental delivery, I agree with Upsha. She said something really important, which is, okay, you delivered, and if I see in like 2 minutes, like 300, 400 cc's of blood loss and the placenta is there, the resident look at me like a zombie. I'm like, please take that placenta out manually. They look at you, like, are you certain? I'm like, yes, nothing is going to happen. I don't want this patient to bleed so heavily, especially if she's twins or any other risk factors. So I agree. However, we also have to teach them, hey guys, if there's a lot of blood loss, don't be scared. Put your hand inside and just peel that beautiful placenta out. Okay, and I hope the fellows do the same thing too.
Yeah.
And to talk about the case of opening the cervix, I wanted to share a complicated case. I was just the MFM who was consultant on it, and a very fascinating case. But we all learn. As you know, I worked at a place that had a very high delivery volume, and this patient had 2 prior sections. So everything was done beautiful, and then postpartum, she had fevers, and turns out to be that her cervix was so much stenotic that no blood came out. And she had huge hematomas inside her uterus and unfortunately ended up with a hysterectomy. So basically, you know, I get it. I hope that everybody's cervix is going to be open to get that blood out. But from that, because of that case, if a patient have had a C-section, I do open the cervix with the ring forceps, basically very gently. And yeah, that's it. So I think we all, you know, we shape what we do with what we've seen also. So that was a very sad case. Yeah, but these things can happen. Thanks, Dr. B. Yeah.
No, I think the important message is, you know, we all have experience and we can remember a case or two. Just be aware that, you know, there are randomized studies and meta-analysis, like, you know, this is almost,
Yeah.
you know, 4,700 patients randomized. And so, you know, what you do routine is one thing, and, you know, some cases in which things may be different, you know, may certainly change.
Absolutely, yeah.
But this is the overall thing. So I think this has gone back and forth, and I still have it. I don't have this is an old slide set. It's saying the same thing, but so I like to exteriorize the uterus. I think if you look at there are many meta-analysis, many trials. I think overall there's not much difference. So if you don't exteriorize the uterus, keep it inside and repair the uterus inside, that's perfectly fine. I put in, you know, easier repair because I feel, you know, the uterus is externalized. It seems to be easier.
Yeah, it's like less hands needed, right? Like you don't need someone with holding
Yeah, but
a
what
wrench
happened
or 2
is
leashes, you know.
it is easier to repair like better visualization. You know what the resin is doing.
Yeah,
And,
that's the other
and you
thing.
don't need too many hands on the retraction. But at the same time, they need to learn how to do it without exteriorization because sometimes there are
Adhesions, yeah.
Do it, and then they suddenly are unable to proceed because they never done it in the past and they got stunned. For those cases when I can or don't want to exteriorize, I use the bladder blade as a retractor because it's more powerful
Yeah.
and covers more area.
Yep.
So you use the bladder blade to lift, and now you can have better visualization. You know, I used to do the C-sections by myself with the Ortec, and I was basically holding the retractor in one hand and repairing with the other one. Because I mean, you have to adapt, you have no help, and so and you have much better visualization. I did not exteriorize uterus before coming to you.
I think the other thing, and this again, it's just like case dependent. If you just look at it, you could say I can repair this without exteriorizing or not. But I think especially to be cautious for the C-sections in labor or arrest of descent is you can miss that inferior extension.
Yeah, yeah.
And
you
if
need
you're
to
not
explore
being careful.
Sometimes look at the posterior wall to see if there's any problem with the decompactation when you.
Yeah, when you I also always look at the broad for like hematoma in the broad, which can.
I have been in 2 cases where there is a posterior colpotomy during the engage happening. Or rotation, so it's very
Rotation,
hard
right.
to say when that happened. They try attempt a rotation and you can cut with your fingers the.
Just curious, I know it's a super small sample size. How many people exteriorize?
I can sterilize without the
So
plan for
most,
the
okay.
routine.
Yeah, just curious.
I won't
I
exteriorize
routine,
That again?
I routinely repair inside too, more for like education for everyone, but I always feel like the less that we do, I don't know if they looked at like pain control post-op in these studies or not.
Yeah.
So they did, you know, and the latest, again, I apologize for not having the latest slides, but the latest meta-analysis shows a little bit more nausea and vomiting.
Yeah, that
With exteriorization.
The patient are suddenly enjoying a baby friendly, and then you put the uterus out, and then the patients became nauseated and cannot.
Yeah. Previous meta-analysis did not show it. but the latest meta-analysis shows more.
Oh, it did. Yeah, I mean, that's what I would expect
It is.
too. Oh, that's interesting.
Like everyone said, before you
Actually,
need to also evaluate because sometimes some people like try extremely hard just to exteriorize and then they have trouble putting it back in when you could have just repaired it inside too, especially with the data showing that there's really no difference between the two other than the easier repair.
And then also like, again, even if you're just thinking case dependent, the patient that's not having as great pain control, like, you know, we all know, like when you take the uterus out, that's like an immediate. So I think, yeah, it's good to know. I should probably do more.
I'm mentioning a little bit, it's a, 15 minutes or so before, I'm mentioning to stop only because I do have a new slide set. And I know I'm not gonna get done to the end anyway.
Okay.
So if it's okay, I want to show you that better slide set.
to also mention that there is a technique to extract the uterus and the technique to put it back. It's not just you can do whatever you want. Is that there is a way to do it.
Yeah.
Wonderful, thank you.
Any